So I'd like to thank Dr. Chauhan and all the organizers for inviting me to give you guys a little bit of an introduction on imaging studies that can be used for evaluating neuroendocrine tumors. I've been working at the university for about a dozen years now, and I'm trained in radiology and nuclear medicine. And we see a lot of these imaging studies every day, so I just want to kind of share a little bit of things that we do on a day-to-day basis. So, I divided the different imaging studies into two different categories. I'm going to talk about some anatomical imaging studies like CT or MRI. Anatomical imaging studies are really designed to look at the anatomy in very fine detail about all the different organs in your body. And functional imaging studies, which are nuclear medicine studies, which are designed to look at physiology, different biological processes, and they're very specialized, and I'll go into each one in more detail, but the two main areas of functional imaging studies in nuclear medicine are SPECT and PET. And we'll talk about each of those on different slides. So first we'll talk about CAT scans, which I'm sure most of you in the audience have had a CAT scan. It's one of the most commonly used modalities for staging of neuroendocrine tumors and assessing response to treatment. CAT scans are widely available. As you know, you can go to any imaging center pretty much in the country and they have CAT scans available. And it's all relative, but they actually are a little bit lower in cost compared to other imaging modalities like a PET scan or MRI. And CAT scans really provide excellent spatial resolution, which just means that we can identify lesions very well in fine detail on the images. And if I could use my pointer, this is a CAT scan of the abdomen. This is at the level of the liver, which is here, and the pancreas, which is here. These are the kidneys. And with the CAT scan, we could really identify lesions extremely well with the use of contrast. So there's two different types of contrast agents that we can give in radiology. One is intravenous contrast, which goes into your vein, and then there's another type of contrast that you take by mouth, and that goes into your intestinal tract. But the intravenous contrast is really important for us because it can outline where a lesion is. In this case, this patient had a lesion in the pancreas. This is the head of the pancreas here. And there are also a couple lesions in the liver, which you can see here, which appear as bright as compared to the rest of the background liver. And one of the unique things about neuroendocrine tumors is that they tend to have a very high blood supply. They tend to be very vascular. And that feature really allows us to image them with a CAT scan and also with an MRI because we could look at the flow of contrast going to all of those lesions. You may notice that when you have a CAT scan done, you might go in through the scanner a couple times. That usually means that we're looking at different phases of the contrast. So if the first time you go in, it's probably right after you receive the intravenous contrast. And that's usually an arterial phase, or in other words, this is an arterial phase image where we can see that the uptake in the aorta is very bright. And neuroendocrine tumors we see them best on this arterial phase because of their vascular blood supply. The other phases that when you kind of go through the scan are just kind of more delayed phases. We can have a venous phase where this is the inferior vena cava, which will be brighter on the venous phase, and a delayed phase where their kidneys will actually have some contrast that start to excrete. So we could use these different phases of the CT scan to characterize lesions and to see how the lesions and if they've spread to other organs. So moving on to MRI. MRI uses strong magnetic fields to produce images of the body, and this is different from CAT scans, which use ionizing radiation. So one of the benefits of an MRI is that it doesn't use radiation to produce images. We're using very strong magnetic fields. But we can get very good contrast resolution on an MRI just as we can on a CAT scan. But in addition to that really good resolution and the anatomy and to see if the lesion has spread to other structures, we get additional information that's unique to MRI. We could look at it's called T1 or T2, which basically looks at the water composition of different lesions. That helps us to characterize lesions if maybe they're fluid-filled or cystic, or if they're more solid. We can clearly see that on an MRI. If you've been on treatment and the lesion is responding well and it's becoming necrotic, you could also see that on MRI based on these different sequences that we use. So MRI provides additional information than a CAT scan, and it's the same, really great, excellent anatomical resolution. MRIs do tend to be more expensive, and they do take longer. A CAT scan can be done in 5 to 10 minutes, and you're done. MRI usually will take between a half hour to an hour by the time the whole study is done. But it does provide us additional information in select cases. So moving on to so those are the two, oh, sorry, I think I skipped a slide. Okay, so you might ask, when radiologists are reviewing CAT scans, how do we determine if you're responding to treatment? So there's different criteria that can be used. The most common criteria is called RECIST criteria. The criteria itself is not that important for you guys to know, but just to realize that there are specific criteria that we use to determine if you're responding or not. And we can categorize patients as having a complete response, a partial response, stable disease, or progressive disease. And these are very important criteria to determine how we're going to continue with treatment. Do we need to try a different medication, or do we continue with the same treatment because you're responding well? So just to kind of give you a general overview, a complete response will basically mean that all the lesions have disappeared. So that would be obviously our best case scenario. A partial response is a reduction in size of at least about 30% or so. And when we talk about changes in size of the lesions, we're comparing the baseline study, so the first scan that you've had before the treatment, either the first scan that you've had when the diagnosis was made, or the first scan before the treatment was changed. So that's considered our baseline scan. And then we compare that to the next scan, which will be done either at specific time points, or it can be done when you have a change in symptoms. So we compare those two studies, and if there's a 30% reduction in size of the lesions, then that's considered to be a partial response. And progressive disease was if those lesions have increased in size by 20% or so. So that's how when we're looking at, and anything that's not partial response or progressive disease, we're considered to be stable disease. So that's when we're reviewing CAT scans, we assign basically a response, and that really guides our clinicians to see if a change in management is needed. So moving on to our functional imaging studies, SPECT is an older technology, but it really, when it was first developed in nuclear medicine, it was a major advance because we could actually see not only the anatomy, but we could look at the functional status of different tumors. And one of this is an older agent, and some of you might have had an Octreos scan before, but this is what was our first agent that looked at our somatostatin receptors, and it was really was a game changer when it first came out. And I'll show a little bit in detail what an Octreos scan looks like. And then another type of a SPECT study that we use in nuclear medicine, it's called MIBG, and that's looking at pheochromocytomas. And I'll show you what that looks like too. So to start off with Octreos scans, as I said, it's a functional imaging study that targets somatostatin receptors. The particular subtype of somatostatin receptor is type 2, is the one it really has its most, it binds to with greatest affinity. In an Octreos scan, we get a whole body image. So in a CAT scan, usually it's dedicated to one particular part of your body. But with an Octreos scan, we can image the whole body from the head to toe, and we can see where the somatostatin receptors are expressed. What lesions in the body are showing have these high abundance of somatostatin receptors. So this is what a scan looks like. This is called a planar image, or almost like an X-ray of the body. And you could see that in the liver, there's some areas that have a little bit more uptake than other areas. And then we could actually use these images, these SPECT images, and fuse them with a CT to get some more anatomical detail. So we could actually see on a CAT scan where these different areas of uptake reside. One of the drawbacks of the Octreos scan is that it's a lower resolution study, right? I mean, even for me, who's a trained radiologist, these images are a bit blurry. And the lesions can be a little bit difficult to see, even for a trained radiologist. Another thing, a little bit of a drawback to an Octreos scan is it requires 2 days of imaging. So for those of you who might have had an Octreos scan done, we usually do the injection, then we wait about 4 hours to do the imaging, and then you come back the next day and we do another set of images. So it's a 2-day study, and it can be quite cumbersome, and the images are a bit blurry. But this was really a major advance when it came out, and it really kind of changed the way we think about neuroendocrine tumors, because we're actually able to look at these somatostatin receptors in your body on an image. A little bit about MIBG scans. These aren't done very much nowadays, but when they were first developed, were very useful for identifying pheochromocytomas. This is what an MIBG scan looks like. Again, we could get an image of the whole body from the head to toes. This patient had a large pheochromocytoma in the left adrenal gland, which we could see here. This was a case that obviously you could see from across the room. But for smaller lesions, again, this is a kind of a lower resolution study, a bit blurry as the octreoscan scan also is. We could fuse these with a CT also, so that's called a SPECT CT if you've come across that nomenclature before. MIBG is labeled with iodine, I-123. So in all nuclear medicine studies, and I'll talk about this when I go over PET as well, usually there's a ligand, and then there's a radioisotope that the ligand is attached to. And the radioisotope, which in this case is iodine, allows us to actually produce the images. It's the ligand will go to certain places in the body and will bind to them, attach to those areas. And then we're able to visualize where that biological process or where those receptors are in the body by using a radioisotope. In this case, for MIBG scans, it's I-123, which you may or may not know that actually goes to the thyroid also. So in this case, the thyroid is actually pretty bright. So for MIBG scans, one of the things that we ask patients before the scan is to take a thyroid blocking agent, because otherwise there's unnecessary radiation going to the thyroid. For those of you who may have had an MIBG study, we usually ask you to take Lugol solution or potassium iodide before to block the thyroid gland. And this also requires 2 days of imaging. We usually image at 4 hours and 24 hours. So it's a 2-day study. Another drawback to the MIBG scan is there's a whole list of medications that we ask you to be off of before we could actually do the study, because they interfere with the uptake. In this case, when we look at MIBG, we're actually looking at the uptake of norepinephrine. So there's a bunch of medications that interfere with that uptake, and you have to be off of these medications for up to 24 to almost some of them you actually have to be off for a full week. So in practical terms, it's a little bit, you probably haven't had an MIBG study just because from a practical standpoint, it's a little bit difficult to do, but it does provide useful information and was very helpful when it first was developed. So moving on to PET scans. If I could advance the slide. Okay. So PET scan, or positron emission tomography, was really a great advancement in all of oncology imaging, in particular in neuroendocrine tumors, because we have very, very specific agents that look at neuroendocrine tumors that are not taken up by other types of cancers. And that's the dotatate scan, which I'm sure most of you have had. And that was a major advancement over the octreoscan scan, and I'll show you the differences between the two. And the other type of PET scan that we do for neuroendocrine tumors is called an FDG PET scan, which looks at glucose metabolism. And I'll show you what both of those look like. So this is a gallium dotatate PET CT. And this is the same patient. An image on the left-hand side, this is an octreoscan scan in this patient. And this is the same patient using a dotatate scan. And you could see it's almost as putting on a pair of glasses, right? I mean, the octreoscan scan is a very kind of grainy image. You could see the lesions, but they're quite blurry. We see a few lesions. There might be one up here, like in the upper chest. There might be a couple in the abdomen, maybe something in the liver. These are probably lymph nodes. But we could see in the dotatate PET CT that clearly see that these lesions are, there's many more lesions than we see on the octreoscan scan, and the clarity is much higher resolution. So this is this was the major advancement when dotatate PET CT first came out, because we could see things that we never saw before, and we could evaluate how patients are responding to treatment in such fine detail that we weren't able to do before, other than by looking at on the CAT scan. One thing I should say that when I was talking about the response to treatment. When radiologists look at CAT scans, we're just looking at the size of lesions, right? We're measuring the size and see if they've changed over time. There are cases when the lesions may not change in size very much, but from a physiological standpoint, they actually did respond very well. And that's where PET scans are so helpful, because there are lesions that don't change in size, but like these lesions here will actually reduce in uptake, and that means that you are responding to the treatment. So it's really that functional imaging really has changed how we evaluate patients how we assess the response to treatment, and it's really been a big improvement in how we can manage neuroendocrine tumors. Dotatate scans have about 100% higher affinity for that somatostatin receptor than the Octria scan, and you could see the difference in the images here. Another nice thing about having a dotatate PET CT is that we give you the injection and then we can image 60 minutes later, versus that Octria scan, which is a 2-day study. You may ask, why do we need to wait 60 minutes after we give, the injection of the radiotracer? And that's because we want the radiotracer to circulate through the body and to bind to those receptors. And for every imaging agent that has been approved by the FDA, they do studies to determine what would be the optimal time to image to allow that receptor binding to occur. And for the tracer that didn't bind to the receptors to clear from the body. From a radiological term, we call that the tumor to background ratio. But basically, we wanted to pick the optimal time that we have receptor binding and we have anything that hasn't bound to clear from the body so that the lesions appear as bright as possible and allow us to visualize them better. So that's why we have to wait for 60 minutes to basically allow for that receptor binding to happen and for whatever is extraneous to be excreted from the body. So there's 2 different types of dotatate PET scans. One is labeled with gallium-68, and the other one is labeled with copper-64. Now you may ask me, what's the difference between gallium-68 and copper-64? So the ligand or the actual receptor that we're imaging is the same between the 2 studies. It's the dotatate ligand, which binds to the somatostatin receptor. The only thing that's different is the radioisotope that we used for the imaging purposes. Gallium-68 has a particular half-life, which tends to be a little bit shorter than copper-64. So copper-64 just gives us a little bit more flexibility as far as when we order the study, order the tracer from the pharmacy and have it delivered to us. It gives us a little bit more flexibility because we have more time to play with, whereas gallium has a much shorter half-life. Another property of copper-64 is that it has a little bit better clearance from the background. You can notice that on these images, there is a little bit of activity normally in the liver. We want some of that liver activity to clear over time before we start to image because we don't want to, that normal activity could obscure if the cancer has spread to the liver, for example. So with its copper-64, the background activity clears a little bit faster, so it just provides a little bit better resolution for our radiologists to be able to interpret the studies. Now, if you showed me in a given patient, if you put a copper-64 dotatate and a gallium-68 dotatate side by side, it'd be very difficult for me to determine which, to distinguish between the 2. But there are subtle differences, and copper-64 is a little bit better. It certainly in the literature, it does show that there are some benefits to doing copper-64. But the mechanism is the same. We're still looking at those somatostatin receptors. One thing that I should mention about dotatate imaging is that we're really focused on imaging well-differentiated neuroendocrine tumors, or usually grade 1 or grade 2 neuroendocrine tumors. Those are the ones that have the most somatostatin receptor expression, and they're the ones that will have the highest uptake on these dotatate scans. Now, we can use them for higher grade or for grade 3 lesions, and the literature has shown that about 80% of patients, even with a grade 3 neuroendocrine tumor, can have some uptake on a dotatate scan. So for higher grade lesions, your doctor might still order a dotatate scan because there is a chance that we could see uptake on the scan. In neuroendocrine carcinomas, which are more poorly differentiated, about 40% of cases have uptake on the dotatate scan. So these are really the most benefit of doing a dotatate scan is for these well-differentiated lower grade tumors because they have the highest expression of somatostatin receptors, but we can do it in higher grade lesions as well. FDG PET is the other type of PET tracer that we can use, and this is used for pretty much all types of malignancies. FDG PET is very commonly performed. Basically, with an FDG PET, we're looking at glucose metabolism within the cells, and cancer cells tend to divide rapidly, and they use a lot of glucose in order to divide and to spread to other areas. So we utilize that property in order to image them. FDG PET is, it's very well established. We use them for neuroendocrine tumors. We use FDG PET for higher grade lesions. Usually those with grade 3 or grade 4 poorly differentiated neuroendocrine tumors is when FDG PETs are more helpful. And actually, when you do an FDG PET, I don't know if I press something. If you do an FDG PET on a patient in a well-differentiated tumor, it actually might be negative. It actually might have no uptake whatsoever. Okay, I'm almost done. Yeah. So in a well-differentiated tumor, that FDG scan actually might have no uptake at all. It will actually be cold. This really provides us with complementary information to this dotatate scan. And this is a patient here, which we did a dotatate scan on, which is the image on the left, and the FDG scan, which is the image on the right. And you can see that some lesions, are very well seen on the dotatate scan. This lesion in particular is hotter on the dotatate scan than it is on the FDG scan. This lesion here is probably hotter, we see on the dotatate, we don't see at all on the FDG scan. There's probably a lesion here, probably in the bone, in the pelvic bone, which we see on the FDG that we don't see on the dotatate scan. And this just kind of shows you some of what has been mentioned several times already in this conference, is that neuroendocrine tumors tend to be very heterogeneous. And even in one particular patient can have different types of tumors. They could have some that are very well differentiated, some that are well differentiated, some that are not as well differentiated. Some of them might be hotter on dotatate, some of them might be hotter on FDG. And some of your doctor might want to order both studies in order to kind of look at that heterogeneity and to help to decide on the treatment. And this is the last thing I wanted to talk about very quickly. It's called the net PET score. Basically, we can do both an FDG scan and a dotatate PET scan and compare the two. And we could assign a score. So a score of 1 would be like all the lesions are positive on that dotatate scan and not on FDG. And a score of 5 would be all the lesions are positive on the FDG scan and not on the dotatate scan. And in the middle, we kind of classify lesions based on if the uptake is the same on both, if they're hotter on dotatate, or if they're hotter on the FDG. And the reason this is important is because lesions that are hot on that dotatate scan tend to respond better to treatment and patients tend to have better outcomes. Whereas the ones that are higher grade and tend to have uptake on the FDG PET, usually have a poorer prognosis and might need some more aggressive treatment, taking into consideration what we're seeing on imaging. So just in summary, I kind of went over, if I could, some anatomical and functional imaging studies that have improved dramatically over the years. It really allows for a precise measurement of lesions and the functional and how functioning those lesions are, in the body. And we can use the information from these different imaging studies to personalize, treatment decisions and to guide management. So thank you very much. That was my talk, and if you have any questions, we'll have the panel at the end.